We start with apologies, and as you will have noticed, we've got apologies from Nicola, who made a tactical error of following our best advice, which is do lots of exercise, and has managed to bash her hand in quite badly, and is seeing the the doctor. Apologies. This morning, so I'm standing in for her. And we've also had apologies from Sarah Blow and Josh Potter, and somebody representing, yes, hi, welcome. And Mike, I think we're expecting, and I don't know what's that on there.
That's James Murray, who we also.
James Murray was, we saw him, so we assume he's going to be here. Anyway, so apologies. I think we are quorate despite all that. Any declarations of interest above and beyond the standing ones? If not, clinical chair's opening remarks. Well, I've had a couple of things that Nicola would have wanted to say had she been here, concerning membership of the board. The first is that Chris Savory's term, which was due to end imminently, has been extended till the end of this financial year.
Next financial.
Next financial year.
Yeah, a bit like Brexit, really, isn't it?
We're ahead of ourselves here. So thank you, Chris, for doing that. The reasons are fairly obvious about all the questions we'll be discussing later on about what the future is and so on. And the West Wandsworth reps, I think their term is also due to finish. And Zoe and Rua have agreed to be extended, I think, till the end of June. And there will be elections, I'm told, in the meantime. So thank you very much, both of you. Any item, minutes? I guess items any other business while we think of it. I've got one item for AOB. Has anybody else got anything they wanted to? Any other items for AOB that anybody wanted to flag? No. Okay. Shall we go to the minutes then? That's the meeting of the 9th of January. I'll take the page. I'll take them page by page. Call out any comments you have. Page 1 or 13 if you're looking at the pack. 2, 3, 4, 5, 6, and 7. Okay, people happy that that's a fair and accurate note of the meeting? Thank you very much. And matters arising, I think there's only one on the action log, which is James. This is an action which I've personally been agitating for about the entirety of the history of the CCG.
You have indeed. I did get in touch with somebody, so I'll chase that up. So, because I haven't had a response, I'll leave that one.
Okay, you have to follow it up there, have you?
Yeah.
Thank you very much. That's helpful.
Unsuccessful.
Well, that would be a big change. Right, so shall we go on then to the planning round and the annual operating plan? And James, are you going to say something?
Yeah, so I'll introduce the suite of papers that you've got here, which fall under a single cover sheet, and just clarify what we're asking the board to do today. You've got 3 papers. One is the commissioning intentions, which Katie Thomas will speak to. You've got an update on the CCG's financial plan, which Neil will speak to, and you've got an update on our proposed performance trajectories for 1920 as well, which John Atherton will speak to. In terms of where we are in the planning round, the commissioning intentions are for approval. And have been through the relevant processes internally that Katie will briefly highlight as well, some of the key aspects of those. The CCG's financial plan update is for noting at this point because we don't have all the moving parts of the financial plan as yet. We're still in, as you can understand, negotiations with most of the providers, and the proposed performance trajectories are also for noting at this point because they are not as yet agreed with providers and regulators as well. So probably not much more for me to say. I'll hand straight over to Katie to go through the CIs.
Okay, thank you. So I'll take the report as read and pull out some key points. So you'll see in the pack that there's a significant amount of detail about the programmes of work we're undertaking across the CCG, and a lot of work has happened since the commissioning intentions were circulated to providers back in September to flesh out the detail of the plans and to pull together the associated QIP values, which are detailed in the pack. I think that a useful lens to consider our plans through is the summary that's in the packets. I think it's page 29 around the long-term plans, but pulls out the key themes and objectives that are articulated in the long-term plan, and that having been published since the commissioning intentions were originally developed through the autumn and winter, it's a useful opportunity to just reflect and on how we're progressing and developing the programmes. And I think absolutely it's the case that the work we're doing fully addresses all of the objectives in the long-term plan, and we've been obviously working on a lot of those things for Wandsworth over the years, and it helps us just crystallise the work that we're doing. But just to pull out, I think, three main themes in terms of ways that we can categorise the work we're doing. I think the first one would be I'd categorise as out of hospital, community and primary care. So I think what you'll see in the pack is there's a raft of schemes that detail the work we're doing in a range of areas, so things like care homes work, diabetes, working with patients with multiple long-term conditions, admission avoidance programmes, paediatric integrated clinics. So there's a whole raft of schemes, those are just to name a few, that basically are around integrated teams of professionals working across organisations to try and support people to stay healthy in the community for as long as possible. There's the second tranche of schemes which I would probably categorise as in the theme of sort of well-being, empowerment, personalisation. There's a lot of detail in the pack around the work we're doing with mental health, so things like extending the reach of primary mental health services to patients with long-term conditions and targeting particular population groups, work around mental health crisis cafes, self-management work for diabetes, and there's a significant programme of work around continuing health and personal health budgets as well. So I think there's a tranche of schemes in that category. And then the final group of schemes, I think, is in the acute transformation category, which is a vast programme of work with an ambitious outpatient transformation programme with St George's in particular, across a range of specialties. Also pieces of work in the outpatient redesign, sort of moving services into the community category, and significant work also in urgent care, so the urgent treatment centre agenda, ambulatory care, and other key pieces of work in the urgent and emergency care domain. And I think just to reflect on that, so there's obviously, it doesn't do justice to the vast range of work that's happening, but I think what the slide pack tries to pull out is the key priorities in each area and the significant partnership working that we're doing with our colleagues across local authorities, the trusts, GP practices, voluntary sector and patient groups as well. And I think it's probably important to note that there's a significant interdependency for some of these pieces of work with our colleagues in the trust. So an example of that being the outpatient transformation piece at St George's. We have a joint partnership board with the trust around delivering that programme, but there's a significant interdependency between the partners in terms of the ability to deliver on that programme. But I think we've got a good foundation in place for being able to take that forward. And just a final point really to touch on is around the process in terms of how we pull all of this together. So you'll see in the pack there's a slide on equality impact analysis and also quality impact analysis. Pulls out some of the themes, so each project undergoes those processes and there's a raft of documentation that supports that. The slide pack tries to articulate some of the key themes that we found as part of that process. I think it's just a useful opportunity for us to sense check, hold ourselves to account in terms of how we're approaching the work that we're doing, and has pulled out some interesting debates. So some of the pieces of work that I'm involved in, for example, there's been a good conversation happening with the Trust, St George's, around the outpatient transformation piece, so where it's turning appointments from face-to-face into virtual appointments, thinking about how we're making sure that we're enabling that for all population groups in an equitable way. So there's those conversations going on across the programmes, trying to make sure that we're holding ourselves to account for the way that we're delivering the work that we're prioritising. So those were the key points I was going to pull out. Happy to take questions now.
Thank you very much. Any questions, comebacks? Please. Samantha.
Yeah, thanks. It was really interesting report and really thorough and really well laid out to make it accessible. Thank you. One of the things that the slide that you took us to in terms of the impact assessment and the highlights, I was wondering about the risks in terms of inequalities and the potential impact on carers and what we're doing with the local authority in terms of supporting carers at home, which may well include young carers as well.
Yeah, so I mean, it might be that colleagues want to comment as well. So I think there's obviously ongoing partnership working with the local authority around carers and identifying and supporting. Julie, do you want to jump in?
Yeah, so we have been working on a young carer strategy anyway across the borough, and any of the quality impact assessments and equality impact assessments have now gone through a more robust process within the CCG. So they've had a look at from the quality team, from the equalities team, and with each of them where there was some challenge that was put back, we will now have a plan and an action for each of the areas as to how we will address that throughout the process. So it's not just been done now and that's the end of it. There's an ongoing piece of work that we'll keep doing. And we'll continue with that. The carer strategy we will work with the local authority on anyway, and we're doing that across the board, across the local delivery unit, but it is one particularly for Wandsworth.
Chris.
This is a good paper, and I commend you and your colleagues for this. I think it clearly sets out what the intentions are. I spent last week in an urban authority in the north of England as part of a review team by the LGA. And one of the things the authority asked us to look at was the pressures they were facing arising from an increase in children with special educational needs. And they were having an enormous surge in demands, occasioned by or caused by a big increase in exclusions arising from academy schools. Now, I can't see in the section in here that we have a specific programme. Does that mean we don't have this problem?
I'll take that. So Wandsworth has seen, like all London boroughs, a significant increase in demands on special educational needs and disability services, and has also seen increasing rates of exclusion and pupils going into pupil referral units as well. We have a couple of pieces of work that we've been doing, so you'll be aware of the work that the commissioning team have been doing with leadership from Tom Coffey around our autism and learning disability pathways, particularly improving access both to diagnosis and also to post-diagnostic support. And we also have a number of schemes under our CAMS local transformation plan, specifically psychologist support to pupil referral units, which we recently improved continuing, to make sure that where there are students who are ending up in the exclusion PRU pathway, whether it's due to LD or due to other factors, that we are able to support those individuals in terms of their mental health. I don't think that we've got it absolutely perfect, and I think it's an area that we'll continue to work on, but it's one of the areas that probably at a level of detail that doesn't quite make it through to this pack, but has been one of the commitments that we've made under our mental health investment standard this year.
Thank you. Huda, will you come in on that, or Julie?
Just so we were working quite closely with the local authority when we did the youth offending team review, and that area did come up. It's a piece of work that the local authority need to do quite a bit of work on themselves. We do sit on the yacht board, as it's called, with them, but the feedback was that the health offer within that was actually very good, and that there wasn't a requirement for health to do too much more. Representation on that board will continue, and we will support the local authority with that, because there is a higher level of exclusions from schools in the borough.
Thank you. Huda?
Yeah, I just want to add, it's something we're taking very seriously, and part of the action plan during the review focus on exclusions. And exclusion, there's research shows that learning disability is a risk factor for offending, just because of the confounding factors, whether it's exclusion or other factors. So yeah, we're taking it very seriously, and it's part of the action plan following the youth offending work.
Stephen, if I can just come back briefly, I'm pleased to hear the evidence, which hasn't come as a surprise, but I think it is worth making sure we don't lose sight of, that there is close and harmonious working relations between the work that we're responsible for and the work of the local authority. Without saying anything about where I was last week, that was not the case where I was last week.
Okay. Anything else on this part of the overall pack? Should we go on then to the finance? The real question here is, can we afford all this?
Well, we'll start. I think you know the answer to that one, but anyway. So just to say, this pack here is really just a refresh of the previous packs that I've brought to the last two board seminar positions. There's a couple of extra slides that have been included in there, which you've got slide 3, which sets out the overall position and the overall aims of the system. So it's a very good summary in terms of how the whole thing comes together. And then on slide 6 is an extract from what is a very detailed financial plan that sits behind that, but clearly is the one that shows that Wandsworth's contribution to the overall system position is a break-even position, and across all the various service lines you can see how that's actually broken down. We've had a 5.6% uplift in our allocation, and slide 7 attempts to show how that allocation would be divvied up between the various areas. I think one of the things I want the board to note is the underlying position. So I've raised that before, but I just want people to keep their eye on that. At the moment, Wandsworth's underlying recurrent position is positive, but a lot lower than it's ever been in previous years. So that is a good indicator of the financial health of the organisation. So we certainly shouldn't be resting on our laurels, and obviously transformation is going to be key to getting us back into better financial health. You'll also note that there are significant uplifts around NHS providers. So usually this will be through the national tariff payments that has been agreed. So is circa 3.5% of our 5.6% allocation would just be effectively paid through to providers, but to pay for the same activity in 1920. It's a little more complicated than that, and we are continuing to negotiate, which is one of the reasons why this is coming here today to note, really, because we haven't concluded those negotiations with providers, but we're clearly looking to try and get a different contractual model than the model that we've operated in the past. That then may pay some dividends in terms of having a little more certainty in terms of the financial position for 1920, which may mean that we can be we can look at our QUIP programme and whether or not it needs to be at the level that we've set at the moment, which is around £15 million. Also to note that the mental health investment standard is 6.3%, which is 0.7% above the allocation growth that we've received. And in addition to that, primary care and community care, there are assumptions that significant sums will go into there. So as I say, we're still at the negotiation phase with providers, and so we just need you to note the current position, and as things stand, we believe that we can come up with a plan by the end of March, which is when the final submission needs to go in, which will deliver a break even for Wandsworth CCG.
Thank you. Chris?
I welcome this report as well. I wouldn't want any of the officers to think I'm going to be welcoming everything this morning, but so far so good.
It's only number 2.
I particularly like the breakdown on slide 7 on grounds of absolute transparency about A, where the money's come from, and B, where the money's going to. I think it's absolutely vital that everybody who's involved in this, whether they be providers or whether they be commissioners or whether they indeed be members of the general public, fully comprehend the additional resources that this organisation has received and what we've done with it, and particularly that we have followed, at least if not better, the requirements to invest in priority services, for example, mental health, to name but one. It's really important because so often the media suggests that decisions are being taken at the centre to prioritise a particular service, and somewhere down the line the money doesn't get through. I think it's therefore great incumbency upon us to demonstrate that we've done just that. Well done.
Any comments, questions? James, you happy with this?
I'm very happy, but I will add to it. So, I mean, in terms of the planning round as we go into this year, I think it's fair to say we're starting to see the sea change that we know is coming in terms of how we operate around systems. The planning round review process that we're going through with regulators is being done jointly by INE, and it's only being done through an STP level. So they're looking at how each of the systems sort of achieves its aims. And I think it's fair to say, I think I used this phrase yesterday, if one doesn't balance, you don't all balance, or you all don't balance. So there is quite an incumbent sort of pressure on us as South West London, not just for the commissioners, but providers as well, in terms of how we're working. We've got now weekly meetings with our finance directors across all the system to work this through, because it's quite complicated, and Chris had the joy as a finance chair of me taking them through quite a much more detailed sort of set of presentation around this. And we've also got that at chief exec level, so we've now got regular checkpoints at chief exec level across providers to make sure that we can, all the local systems are working in the way that they need to, and also that we can pull that together as South West London. It is going to be a challenge for South West London. It's going to be a challenge for all 5 STPs. The feedback we had from the session on Monday is you're working in the right way. That's a very positive thing. But they recognise that actually when you look across the provider and the commissioner market, there is still a gap that we'll need to resolve, and that's going to be the focus for the next 3 or 4 weeks in terms of how we seek to get that aligned position. So it's just to add, so it builds on all the good work that Neil and the team have done, but that will be an extra focus that we'll have to deal with this year.
When does that alignment across the whole STP need to be done by?
Well, we're working on the local alignment. I mean, it's been done within local systems anyway. So Neil is working with South West London George's and South West and St George's to do that, and other systems are working on that. We've got a chief exec's checkpoint next week, and I'll be taking the outputs of that to the committee in common that we've got, the finance committee in common for the CCGs the week after. We're required to sign contracts by, well, heads of terms, I think they've slightly softened it now, by the 21st of March, contracts by the 31st of March, operating plans for individual organisations have to go in on the 5th, and the consolidated position goes in on the 12th, but clearly to get the individual positions we'll have to have the consolidated position sorted by the time the individual organisations go in. So it's an ongoing process to answer your question, but there are regular checkpoints in, and we'll use the finance committee in common to update people on that.
Okay, but going just back to my original question, I mean, on the basis of what we know at the moment about the finances, the commissioning intentions we talked about earlier are deliverable in terms of affordability.
Yes, at the moment we have the money to deliver the commissioning intentions, yes.
And where are we on QUIP?
So I think the last, and Katie can correct me if I'm wrong, we were around about £1 million of unidentified in Wandsworth. So we've made good progress, but as always, the key is going to be getting the provider bought into it. But we have identified all but £1 million worth of schemes.
Okay, anything else on the purely financial side of it? If not, we go on to the performance trajectories, which is the third leg of this stool.
Thanks, Stephen. As with previous years, we're asked to set some predictions against a whole host of performance trajectories, some of which, or most of which, were features of last year's plan, some of which are new for this year. Across the 30 or so key performance indicators we're asked to report against, the vast majority, as you can see in the table, we're projecting to be compliant with the various requirements of those targets. There are some areas where, from the outset, we're planning not to be compliant for reasons, some of which will be obvious to you, some of which I can mention in a moment. And there are some where we're planning to be compliant, however we know that will be some challenge for us to sustain that compliance over the course of the year. As James has said, there is a overriding need for us to be entirely aligned with our providers this year, more so than ever before, in our performance commitments. And again, we're always striving for that sweet spot in terms of ambition and deliverability. And against each of these, from a South West London perspective, we put a fair degree of challenge in to make sure that we are getting as close to that point as we possibly can. Calling out some of the individual lines then for a bit more detail, in terms of the accident and emergency standard, we're looking with St George's currently at a range from 90% delivery across the year to 92%, and looking at the underlying assumptions to deliver against the higher threshold of 92%, what that would mean given some shifts recently in activity if they were to be sustained, and in terms of the ED workforce at St George's. St George's are about to begin reporting, or it'll be in the public domain in the next week or so, their month 10 RTT position, having just been through a lengthy process of return to reporting. Their headline commitment is to move from 84% to 88% compliance with the 18-week waiting time standard. Again, we're working on the underlying detail of what that means month to month, and that work remains in progress. In terms of 52-week waits, we ideally would have 0 52-week waits from April onwards, but St George's is still clearing a residual backlog, and somewhere around somewhere under 30 are projected across Q1. We're looking now to make sure that that's as accurate as it possibly can be. There's a fine system in place from the 1st of April for both the commissioner and the provider for all 52-week breaches. So obviously for both patient safety and clinical care, we're looking to clear those at the earliest opportunity, but also there will be a financial impact on any 52-week waits going into next year. And finally, personal health budgets has been an area of challenge for both Wandsworth and Merton CCG over the last couple of years, looking to see what we can do to deliver as many personal health budgets over the course of next year as possible, and annual health checks by GPs for patients on LD registers, again an area that needs some focus over the coming year to make sure we can deliver that. But in summary, a productive planning round so far, some points of detail still to confirm, particularly with St George's, to make sure we get to the point where we can stand behind this set of trajectories as ones that we believe are truly deliverable over 1920.
Thank you. Any questions, comments? Chris?
Sorry, it's me again. There was some publicity this morning about advice from the Royal College of Radiologists about cancer clinics not scheduling patient appointments at the same level of frequency, perhaps, or the same volume, because of some possible anxiety about isotope availability post-Brexit. Now, I appreciate the whole Brexit story is one big uncertainty, but we do have some issues around cancer waiting times, and it seems to me if that becomes a serious issue, those waiting times can only get but worse. Have you anything you can add to what you said about that, since you didn't mention cancer specifically?
We've done a degree of modelling around cancer that's been more sophisticated than previous years, looking at what impact changes in referral patterns are likely to have on demand for cancer services. The particular issue about the availability of products post-Brexit is something that we are continuing to pick up, and indeed the providers are continuing to work on. There's been a number of, with NHS England, a number of Brexit-related preparation meetings. It's part of the business continuity planning, and will continue to be so. There's a further meeting later this week. So it's absolutely part of the risk registers around Brexit, around the wider workforce issues, the wider devices and medication issues which are being considered. So I'll pick up on this morning's news story as well when I get to it, but absolutely it's being considered. Thank you.
Can I just ask a question? You've expressed all these in terms of compliance or otherwise with the trajectory. From a sort of patient's perspective, the question would be, I think, more whether this is going to be at least as good as the current year or better, or are any of these services does the trajectory, do any of these imply that things will be getting worse rather than better, is my crude question.
There's no areas where we're looking to go backwards next year, and there are some where the target has increased from the previous year. So IAPT, for example, is on a rising trajectory over the next couple of years. So that continues to put more demand on the CCG for more people to go through that service. So nothing is going backwards. In terms of the RTT waiting times, obviously the St George's will be included for the first time for a few years when that data becomes available later this month. So although it will look like our performance has deteriorated, of course, our underlying performance has always been the same. It's just a portion of that has not been subject to national reporting.
It may be a presentational point, but I've always felt that we always compare against targets and against trajectories and all that kind of stuff, which is fine, but it's meaningless if you don't happen to know what these targets mean and what trajectories are. And really, it'd be really helpful if we could explain, is this service, or has it historically got better, worse, or stayed much the same? Because then, that's really what you're interested in as a patient.
Absolutely, and certainly in the performance report, with that longer term trend that we give, you can look back and see what some of the actuals are. So for A&E, for example, which we'll come on to shortly in terms of my performance update, January was better this year than last, still below the 90% target that was set as the trajectory, but 1.4, I think, % from memory above where it was last January.
Okay. Right, anything else on this section? We're asked, can I just check, James, we're asked to approve the commissioning intentions, but note the other two.
Yes, that's right.
What is the process for sort of finalising the whole package, as it were?
Neil, do you want to talk about the finance plan?
Yeah, so in terms of the finance plan, we'll be taking that through the finance committee. I still need confirmation from external audit that they're happy for us to approve at the May board. If they say that the May board is too late, then we will have a public board section as part of the board seminar in April, and we can do it in early April, which is what we did last year. So the plan will be ready, the financial plan anyway, will be ready for approval early April anyway, so we can go for that, but I just need external audit to confirm. We'd probably rather leave it till May to then do it as part of the overall public board.
And we'll revert to the performance trajectories in the April seminar.
Okay, so are we happy then to approve the commissioning intentions and to note the other two? Yes. Yep. Okay, thank you very much. So we go on to primary care update.
Thank you, Stephen. So this document attempts to provide the board with a summary of the changes set out in the 5-year framework for GP contract reform, which was published last month. Now, this document represents a really significant shift in the way that general practice has previously been commissioned and in the way it will operate going forwards. And we're still working through what this is going to mean for us locally in Wandsworth. So a lot of the detailed guidance, which is going to support this document, is yet to be published, and we're expecting it before the 29th of March, we're told. Importantly, the changes do come with significant new investment into primary care, again, to be worked through locally exactly what that means for us. But a large proportion of the money is going towards the creation of a network DES, which essentially incentivises practices to come together in groups of 30 to 50,000 registered patients to implement a number of new initiatives, and that includes a number of changes, including the introduction of a number of new staffing roles, which is really, really key to addressing some of the challenges that primary care has been facing. Also, very important to note that the contract talks about the alignment of community mental health and social care staff with these new primary care networks and the appointment of a number of new clinical directors. So each network is expected to have a clinical director who will feed into local transformational programmes. So things like our Wandsworth Health and Care Plan, it's anticipated that the network directors would have a role in feeding into that programme, and we obviously need to work through locally the governance arrangements around that. This is a huge opportunity for us to drive forward the primary care transformation agenda, a number of the areas that we've already been working on in terms of developing the sustainability and resilience of primary care,
including developing the capacity of primary care to manage increasing demand and to manage the shift of care out of secondary care environments, and also to drive forward the integration agenda and things like our MCP model, which we've already talked about at various board meetings previously. In Wandsworth, we have made significant progress in starting to address these changes. We had some primary care at scale funding that came down from NHS England last year, and there's been a number of ongoing discussions with practices across the borough to start to get them to think about how they might form these networks. In terms of other changes that are described in the contract, there's a range of things that will be very, very key to practices themselves. So there's a number of changes to the existing quality and outcomes framework, which encourages practices to make quality improvements that are identified nationally. A number of workforce development issues that broadly build on things that have been done in previous years. There's a new indemnity programme that standardises the amount of indemnity payment and actually part funds some of that as well for all GPs. And there's a real emphasis on the ongoing development of digital in primary care, which again, Wandsworth is really on the front foot with in terms of some of the work we've already been doing around the rollout of Dr. Link, e-consultations and also patient online. So just in terms of next steps, as I say, there's still quite a significant amount of working this through that we need to do, and we'll absolutely be working with our primary care committee to go through some of these changes in more detail and look at what the role of the CCG is in approving this. The primary care team themselves will need to work through what the implications are of the new contract on our existing services. So we know, for example, that some of the KPIs in our PMS contract may overlap with some of the changes, so we'll need to work that through. And some of our planned investments, so things like our care homes programme of work and social prescribing, again, there's some overlap with what's described in the new contract, and we need to work through what the implications of that are. There's also a deadline for practices to have actually formed these networks. So practices have to come back to us to formalise which networks they want to be part of by the 15th of May. And the contract says that the CCG will have a role in approving the formation of these networks. But what that seems to very much be around making sure that there is 100% coverage of networks rather than giving us any indication that we'd be able to perhaps veto any particular arrangement. So again, we're really hoping that the guidance later in the month clarifies that and makes some of the discussions that we're having with practices that much easier. As I say, we do have a number of meetings coming up where we will be working with practices, our LMC colleagues, our federation colleagues and our clinical leads to try and make sure this all comes together in a way that absolutely makes sense for the population of Wandsworth as well. And then we will be working with the primary care committee to sign off those arrangements, and we'll be more than happy to bring an update back to the board once that's done.
Thank you. Comments, questions, and hundreds of questions, imagine. Mike, do you want to start?
Thanks, Katie. I know this is kind of fast moving, but may I just ask you for an update as to where we are with PCN or primary care network engagement? Do we know if all of our practices across Wandsworth now are speaking to each other?
So they are all actively engaged in conversation. I think
necessarily with each other.
Yes, we know they all are all actively involved in conversation. There have been, from what I hear, some very productive meetings in key areas. There have also been some slightly less productive meetings. And I think when we've had these conversations informally with clinical leads and the Federation, we very much see our role as one of being a facilitation and mediation role at the moment. So we have a number of touch points built into the system where practices are due to come back to us to let us know what their thinking is around these network arrangements. And that will then give us an indication of whether we have some outlying practices who we need to work with a little more closely to make sure things come together in the right way.
Carol.
Thank you. Very good paper, covering a lot of ground with a lot of unknowns. Workforce is a key issue across primary care, shortages and all that. Some interesting new roles proposed, some of which have some sort of basic preliminary structure in place. Others I'm not so sure have. There's going to be a lead time for the development of these roles, out of which comes a couple of things. But also, each of the new PCNs will need a clinical director. Now, one question arises from that. What sort of time commit, which presumably will be a GP, I'm not sure,
Very likely.
but will be a GP. So what sort of time commitment will these new clinical directors have, removing them from availability for delivery of primary care? There's an issue there. But also on the new roles, before I let go, public understanding of some of these new roles is pretty basic. I've been in a couple of meetings recently where physicians' associates were mentioned, and there's great anxiety about what would they be doing. How would I know if somebody's properly trained, and all sorts of concerns like that. So I think there's a big, not just trying to figure out what's going on and waiting for the guidance, but a big public engagement, information as things develop that needs to be done on this.
So just on the final point, I think that's really important. And once we do know a bit more about it, I absolutely think we ought to be looking at a sort of communication engagement plan once we're clear how practices are going to work together and can say a bit more about that, I suppose, once some of the moving parts have finished. In terms of the new roles, I absolutely agree there's going to be a kind of a national I think probably gap where actually there's going to be a need to train up new pharmacists and new people to actually fulfill these roles. We are on the front foot in Wandsworth. Over the last year, we've had a number of pilots running, particularly around clinical pharmacists. We also have a plan to roll out a social prescribing model that's been running in Merton in Wandsworth as well. So we have some experience of how to develop those people and how they can best work in practices as well. So that's good news. Likewise, physicians associates, actually, we already have a number operating in practices across the borough, and we actually work closely with St George's on the training programme for those roles as well. So we're hoping that will mean there's a real opportunity to get the people that are coming out of the training programme embedded into practices locally.
But you need to inform the public of what they're doing.
Absolutely, yes. Just very quickly in terms of the point around clinical director, so this is going to come down to the funding that we still need a bit of clarity on. So there is a funding amount dictated in the contract that will go towards that role, and it will obviously be looking at what time that will actually fund. We obviously have a number of clinical leadership roles across the CCG and across the Federation. So I think there's also a conversation to be had about how perhaps we make sure that all those roles are aligned rather than perhaps creating another duplicate process in the system.
Okay, Sam.
Yeah, just a brief follow up on the workforce issue. You mentioned working with St George's around the associate physicians. Obviously, specialist nursing is going to be really key to this, and alongside advanced nurse practitioners, and I think the point about public understanding about what those are and what the competences are is really important, but also not just working with St George's but working with the community providers, because this is going to require new ways of employing and supervising and clinically developing staff in order for it to work, and that needs to be done collectively with our providers in the community, with potentially with roles that can move across more than one area. Thank you.
Jamie, then Zoe.
Thank you. I think actually Carol made most of the points I was going to make. Staffing, big risk. It would be really good to be reminded of the definition of a physician associate. I don't think I actually knew that we had this role operating in Wandsworth at the moment, so it'd be really good to get a kind of just role description.
Good,
yeah. So, Katie, where do you expect to see the final sign off of the networks, how they configure, and what is the role of the Health and Wellbeing Board in this?
So we're still trying to clarify the role of the CCG in this, to be quite honest with you. As I say, the wording in the contract is very loose. It essentially says the CCG will have a role in approving the network arrangements. I think when we've had these conversations informally, and I think we need to continue the conversations through our primary care committee to develop some principles actually around whether there's anything that we would actually say no to, I suppose, because ultimately this comes down to practices being able to work together in a really pragmatic way. There are still lots of unknowns in the contract, so I don't think it's a case of whatever network arrangements they get themselves into, they won't ever be able to change that as well. But it does seem very up in the air at the moment, and I think we'll need to probably come back to you once we've had the further guidance and been able to have those conversations through our primary care committee as well.
Zoe, oh, sorry, go on.
So I mean, I think that in terms of the Health and Wellbeing Board in and of itself, I don't think there is a role set out in the guidance that we've had. I think what we might want to do when we have the opportunity to look at a proposed configuration is perhaps the CCG and the GP Federation, if they're really involved in it, it might be the sort of thing that they discuss at once with Transformation Group and see if partners there, including colleagues who sit on the Health and Wellbeing Board, have got any sort of considerations we should be making, because I think, you know, as Sam's highlighted, the network configuration will have profound implications for community provision, and also if we want to continue to align around effective neighbourhoods that have got sort of multidisciplinary working in, we also need to think about the implications for social care as well. So I think it's a very good thing to be the kind of thing that we pick up using the Wandsworth Transformation Group mechanism.
Zoe and Chris.
It was really just to sort of bring some of that together and just say why this is a good thing for patients, actually. So, you know, primary care is the sort of core of the provision of healthcare, and the idea that it's around the patient allows this to be developed in primary care. As a large practice, we've had experience of working with some of these additional roles. So we have a physician associate, we have had the pilot with the physiotherapist, direct access to physiotherapists, we have a clinical pharmacist working in our practice. And absolutely, I agree, Carol, that it's taken some time and some effort to educate our patient population about the benefits of having these other professionals working in our practice. But now that they are aware of and understand the value of them, they really appreciate them. And as I say, certainly it actually means better care for patients in a lot of instances. So, for example, with the Physio First pilot, actually the patient is getting a better service. Their pathway to the appropriate care is better than if they had seen the GP first. I think, although it can seem, you know, that the patient perception is that we're using this because there isn't enough GPs or isn't enough nurses, actually it's about transforming primary care and thinking about how we can do it differently rather than just because we haven't got enough of. So I think absolutely it's really important to educate patients about that, but this is I think there is real value in these roles in primary care.
Thank you. Chris.
Appreciate it's early days, and clearly there's quite a lot of the details still to be understood, let alone communicated and shared in a broader sense. But this term network contract that's used in your paper implies that there's going to be a change in the contractual arrangements between NHS England stroke NHS Improvement, or whatever it ends up being called in the new world, and individual groups of practices, which is not the situation we've got today. The situation we've got today is individual practices are contracting, and there isn't even a standardized means of contracting within that framework. Now, presumably the intention is to move to something different, or not?
So I don't think, based on what we know so far, there's going to be no move away from core GMS, PMS contracts. What there will be is a shift in the way some of the enhanced funding comes down through the system, so that it comes down through this network contract rather than coming to individual practices. And ultimately, I think what they're trying to drive through doing that is to get practices to look more and more at how they can come together more formally in bigger groups, perhaps, rather than continue with their individual contractor arrangements. But I don't know if other GPs want to comment on how they've read that.
I'd like to ask a question actually on the contracts as well. We also, as a CCG, have contracts, but we do those with the Federation. And through them, as it were, to practices. Will our contracts be affected by all this?
So I think that's up to us to work through, actually. My view is that the Federation has been really, really successful in being able to drive equality of service delivery across all practices within the borough. So I don't think we'd want to move away from contracting with the Federation to make sure that you get that equality. There's a risk that if we started to contract with individual primary care networks, you get that starting to re-emerge again. That said, I think there's a conversation for the Federation to have with primary care networks and with practices about how they see their roles starting to work, particularly given that funding is going to start flowing directly to those networks. And
that's helpful. Thank you. Waka.
Thank you very much, Katie. It's a lovely paper, very informative. I appreciate maybe the mechanics of how primary care networks will come together and operate is as yet undetermined. But speaking to GPs in the borough, there is some consternation amongst them in respect of how funding will flow through the networks. And there is a perception amongst GP practices that within a network, the funding will flow to a lead practice, and then from there, the funding will be devolved to individual practices. And that seems to be causing some degree of unease amongst GP colleagues. Now, I just wondered whether you could confirm whether what I've told you is accurate or not, and secondly, if it is accurate, have you had any discussions with other colleagues which may allay concerns amongst GPs and GP practices?
So I guess the answer to the second part of your question is no, I haven't. Again, I know I keep saying it, but waiting on the detailed guidance, I think, to fully understand this. What we've seen so far is the template that practices have to fill in when they submit their proposed network arrangements, and that requires practices to essentially submit a bank account into which money will be paid. I don't think that necessarily means there has to be a lead practice. Practices may come up with more innovative ways of managing that bank account, but I guess the simplest way would just be to have one practice put it forward. And I think there's probably a role here for when we start to have these conversations over the next month or so about how we can support practices. There may be something about thinking through development of MOUs between practices to try and allay some of those fears and things like that. So I think there's tools that we can potentially work with practices to allay some of those fears.
Thank you, Katie.
Okay, I've got Carolyn, Chris and James.
Could the Federation take on a backroom role?
Potentially.
Well,
yeah.
it's just on that point that it's a potential role for the Federation to take on that role of being the holding the finances.
Yeah.
James.
Yeah, this has come out in a slightly odd way for me, but it is an exciting opportunity. I think all the conversations that you've just had and the points that have been raised, and somebody said we don't know what the role of the CCG is. Well, I think whatever the guidance says, the role of the CCG is going to be to make sense of this and hold the ring on it, because I've heard we can't agree in the practices how we'll get paid. We don't know how the workforce is going to work. We don't know how the money is going to flow. So there's a lot of things that need to be worked through. So I don't think we can sit here and wait for the guidance, and I know Katie's not doing that, but I think what we do need to think about is how some of the mechanics will work, but also actually what are we looking to achieve from this. And we've already worked through the local healthcare plans, or what we're trying to work through as the ones with CCG, and we need to make sure all those things start to align. So I think it's important that CCG doesn't think it's got a passive role in this, because it hasn't. It's got to be proactive, it's got to manage it, and it's got to work with practices to make sure we all get the best out of this. So I think, you know, my line generally with everything at the moment, because I seem to be working in the dark in most things, is you kind of beg forgiveness. So you work up what you can, and then if the guidance comes out and we need to tweak that, then let's do that differently. But the important thing is that the danger of all of this is we can have lots of strands going off in different areas. It's really important, I think, for the CCG, and I know Wandsworth can do this because they do it all the time, that you keep a ring on this and you drive it forward as one sort of route. That makes sense.
Jonathan, do you want to add to that?
I just want to say, I mean, there are some uncertainties, but it's been wonderful to see how practices have looked at the potential opportunities, and we've been speaking for years about networking, but this has given the opportunity to focus on it and to build on the informal networks we've had for many years, working within practices, but we've never really had the time and energy and focus to network. So there's a lot of huge opportunities here.
Okay, Carol, last word perhaps?
Yeah, just one thing that hasn't been mentioned, the removal of indemnity obligations from individual practices to a national program. That has to be a very positive thing.
Yes.
Okay, well, I think about 28 more questions. Rather fewer than that answers, I think, at this stage. I mean, it is a very demanding timetable, it seems to me, from outside. And clearly the ball is going to be very much in the GP's plural court. I guess the question is, how they're able to, rise to that challenge, and what is our role, and to some extent the Federation's role and the LMC's role in, as it were, shepherding this if there are problems.
Yes. Shepherding is a good term for it, I think. And we, as I say, we have various forums set up over the next month to do exactly that.
And what is the process as far as the board is concerned? Are we going to have a meeting of the Primary Care Committee looking at all this in more depth?
Yes. So we've got two things that we're scheduling in. We're scheduling in an informal seminar with the Primary Care Committee to talk this through in more depth and come up with, as I say, perhaps some guiding principles for what we would do if certain things come back and they don't quite meet the needs of 100% coverage and all of those sorts of things. And then we'll have a formal primary care committee between the 15th of May and the 31st of May, which is when it all has to be signed off by, to actually formally approve that. There may well be a process then of mopping up any queries around the edge, but hopefully that will come together within the time frame. I'm confident that we can then report back to the board.
So you come back to the full board in sort of June, July time, is that probably July?
Yeah.
Right, okay. Good. Well, at the moment we're asked to note this, and thank you very much for a very clear paper on a very complex subject, and lots of questions which I'm sure you'll have the answers for in a couple of weeks. Good luck. Right, exec report, James.
Yeah, I'll take it as read and take any questions.
Any questions? No? Okay. Performance report.
Thank you. Likewise, I'll take the overall report as read. Just two things I wanted to highlight. We talked in some detail at our part 2 last month around the RTT position and return to reporting at St George's. The month 10 report will be available from the 14th of March. So after close to 3 years of non-reporting, St George's will be back in the reporting cycle. And as we discussed briefly during the planning item, we're looking now very much at what we can do across South West London over 1920 to make sure that the activity flows are coherent and that the work we did on a joint referral system this year with Kingston and Croydon can be used to best effect over the course of the next year. But at the moment, we're looking at a headline position of 84 to 88% for St George's, delivering against 18-week standard, and they're likely to outturn this year, subject to what's produced on the 14th of March, at somewhere around mid 80%. The other point I wanted to pick up was A&E. So we have seen an improvement in actual performance, although under plan. From January last year, our latest formal reported position, which is 83%, to 84.2 this year, which is positive. And there's a whole host of work going on in this latter part of winter, looking at enabling flow through the department. So a whole new set of metrics that have been in place now since the beginning of February that the department are using to help improve their practice. We've got a rota that we set up in January to make sure we've got a senior commissioning colleague available throughout the week to help with any difficult discharge or patient flow issues, which seems to be having a beneficial effect. Formal detox remain low, often under 20 for the full hospital site, and additional beds that were opened to help with winter pressures remain in place, but overall below 95% national standard, below the 90% local target for January, but strong performance when compared to the rest of London and nationally in terms of the current ED resilience.
Thank you. Any comments, questions? Chris?
You said you were going to revisit the question I asked about cancer when we were looking at the planning thing. So could I invite you to do just that?
Yes. So in terms of cancer performance, we have a separate South West London meeting on cancer performance. Cancer generally is doing very well across South West London. South West London STP is always one of the top performing STPs in terms of cancer waiting times performance. We have some issues with screening and consistently achieving against that target. That is due to low numbers, and it's also due to some complex shared pathways. There's been some recent changes to ensure that's more robust and resilient going forward. And so the other points you make around contingency planning for likely future changes around availability of certain medical devices and drugs, etc., will ensure that continues to be part of that agenda. It is, because that is the fundamental part of the provider planning for Brexit, but we'll ensure that continues to feature.
Chris?
If I can just come back, I hadn't appreciated the anxiety felt in some quarters around the availability of these isotopes. The Secretary of State, when talking about contingency planning, is talking about stockpiling key drugs and the arrangements that he's got in place with the drug companies. As I understand it, from the point I heard this morning, it's not possible to store these isotopes long term because of deterioration. So presumably the nature of the contingency has to be rather different.
I guess there's a wider point about Brexit planning and CCG engagement, which is a separate paper. We were noting this morning that we probably need to look at a wider paper on this. It's certainly been to our exec team, so whether a governing body paper is now needed.
I mean, that's exactly right, John. There's a really important point about coordination of a response to Brexit. There are, we have been through the guidance for CCGs around Brexit planning and the things that we're meant to do, and a lot of it is basically stand by and wait to take action, because actually, we don't as yet understand whether there will be very locally specific impacts. We've had some conversations with local providers around making sure that staff who need to be offered settled status, that's paid for by the provider if they need to, just to understand with the local authority the sustainability of the home care and the residential marketplace as well. But in terms of things like availabilities of relatively specialised drugs and devices, particularly those with short shelf lives, I think it's really important that we support national efforts to do the planning around that on the appropriate scale. And actually, a lot of the correspondence we've seen says, actually do not start to take locally sort of derived actions to stockpile, etc., because that will have a deleterious effect on the overall planning. So I think it's just we're very happy to share the correspondence we've had and the actions that we've taken in the EMT discussion, but it's really important that we see any CCG actions around Brexit in context of the national system.
Chris?
Can I just come back on one point, and I don't want to open a big debate about the minefield of Brexit in the more complicated way, but I would tell you from personal experience, there is huge anxiety on the part of European nationals. My wife is German, and so I'm saying this with some emotion, about how they feel about this country and about how they think this country feels about them. Now, I don't know whether we have European nationals working for us. I'm very sure that our major providers will have a large number of European nationals working for them. So I'm sure there is a very high level of anxiety amongst that group of individuals, let alone the wider issues about the staff and the population, the population that we're serving. So I just make that point because clearly at the moment there is still a lot of uncertainty around this, and people are interpreting settled status as a sort of second-class citizenship, which is, really causing problems in all sorts of ways.
I think that I think what's important from a CCG perspective, so we do have EU nationals, and we've made an offer across South West London to fund the application for settled status. I think the cost has now been pulled back, so it's no longer relevant. But in terms of what we're able to offer, we've offered everything we can. I think what's important from a CCG perspective is that we make sure that we continue to be a welcoming and supportive environment, and somewhere that people want to work. When we come to share the results of the staff survey with the board, you will see that actually, in terms of staff recommending this as a place to work, we've actually improved quite significantly over the last 12 months. So hopefully, I would hope that would mitigate partly any impacts on any individuals who for whom this was quite a challenging issue. I do completely accept your point and your level of personal knowledge around this, which is that it must be very challenging and very destabilising for people who are in that situation.
Okay, anything else particularly on this? I mean, just one question from me is that we're coming to the end of the year, clearly, and some of these are becoming historic, and therefore we'll be into annual report time and so on. Can I ask that when we do have the full year data, again, we sort of do a bit of a reflection on it in terms of what things went well, what things went badly, looking perhaps more than just 1 year. Because otherwise we always live in a kind of very month-to-month kind of world, and we don't step back and say, hang on, this has been going on for a decade or 2 years, or was it a blip or something? So I think a bit of reflection on performance that we never quite sort of seem to...
Certainly happy to do that. If I take an action, then once the full 12 months data is available, we will do with my team a thematic paper looking at the relative successes and challenges over 18-19.
Thank you. Natasha, did you want to come?
I don't know whether this has been done before. It was just a suggestion. Speaking to your earlier point about seeing change over time, whether if there's some other ways of doing it using like SPC, like statistical process control, or other ways of I'm sure people in the room will know what that is, but different ways of showing things over time to show how things are improving against a benchmark.
Yeah, absolutely. We'll do a thematic report, and we'll put the trends and the themes in there.
Great. Thank you very much. Right, finance report, Neil.
Yes, so I'll hopefully fairly brief on this. So just to know, we are on target to achieve the surplus 3.1. Not been too many changes between the last time this came to the board. To note, we've got year-end agreements in place with Epsom St Helier and Kingston. We are very close to an agreement with St George's, and the number that we're close to agreement on is within these numbers in here, so that's quite a positive move. I'm hoping by the end of this week that we'll have that concluded. Really the only outstanding risk I would say would be around Chelsea and Westminster being the other significant providers, so we can start to have conversations there with them. Other than that, I would take the report as read and happy to pick up any comments.
Any questions? No. Thank you very much. Excellent. Long-term plan.
Yes, so there isn't any specific action for the board to take on this today. And I think that actually we've, since this pack was written, we've got a lot more detail around the primary care networks, and we've just had quite a rich discussion about those and a number of things flowing down through those. So I don't propose that we repeat that discussion. And this is a slide pack that's been produced by the South West London Health and Care Partnership team, just to highlight the NHS long-term plan in terms of some of the high-level messages, what it talks about, some of the commitments that it makes. Its commitment in particular to investing more money into the system, but that much of that money in the initial years will go into fixing financial sustainability issues that already exist. And we know, for example, that some providers in South West London have received significant non-recurrent support for 2019-20 as part of some of that new money coming down, but that there is continued investment to be made in transformation initiatives to deliver other aspects of the long-term plan through coming years. If I were to go into the detail anywhere in here, I should probably do all of it, so I won't. I think
seconded.
What I will highlight though is the way that we're planning to respond to the long-term plan. So we asked we expect to be asked in the autumn to produce a South West London level response to the NHS long-term plan. Now, obviously, we've got the local health and care plan process running, which significantly reflects our existing commissioning intentions, and that process is running in each borough. So the intention is that as much as is practicable, the South West London response to the long-term plan will be the aggregation of 6 borough local health and care plans, with some cross-cutting commitments around clinical transformation and a view of overall system clinical workforce and financial sustainability as well, so that it's very much a bottom-up plan, and it very much reflects the work that we've all been doing for a number of years. I think that, you know, what the board should take as sort of reasonable assurance about the Wandsworth positioning around that is when you look back at the commissioning intentions paper we had earlier and those tick boxes against the areas in the long-term plan, Wandsworth has been working on a number of these areas for a number of years, and there's actually quite significant alignment between our local transformation priorities in many of the areas in the long-term plan. Obviously, there'll be a few new areas to pick up, and many of those are within the GP contract. So that's probably all I wanted to say, and probably just to highlight the process of responding to the plan at South West London level more than the content at this stage.
Thank you. Chris?
Integrated care systems, which is slide or page 115.
Yeah.
In that. Now, I understand the bullet points that are being made here, but I think what they share is they are really describing the architecture of the way the system is intended to change, the emphasis on joint working partnership, all of which is commendable, all of which makes sense. What I'm interested in is how will the patients experience integrated care? If it's across the country within 2 years, how is a member of the public going to see a difference? What's the plan that is different in their eyes? How are they going to impact on health and care systems in a way that shows that there is something called integrated care?
I think that's a really interesting challenge, and I think that it will be different not just in each of 44 ICSs, but actually in each local system below the ICSs, because certainly in the 2 STPs that I've worked in the last few years, there's been significant variation in what integrated care means, but on a CCG by CCG basis, and sometimes even on a more local basis than that. I think the answer in a Wandsworth context is that I think through the work that we as a CCG have done over a number of years, a lot of the time patients already do experience very integrated care. When the Health Service Journal published metrics around the operational success of health and care integration nationally, Wandsworth was the second most successful borough in terms of making sure that people received reablement support when they're leaving hospital, in terms of a low level of delayed transfers of care, in terms of people not going back into hospital 100 days after discharge. So there are a number of areas where you can see visible metrics, and they are supported by things like our ECP and PAC schemes, where we're actually bringing together aspects of the system and people are already receiving integrated care. I think what we know is that there are some ongoing structural boundaries to taking that forward and to further developing that in every system. And I think on the ground, many systems are less advanced than us and are not in a position where they're able to provide that experience of integration on a consistent basis. And it was very clear from the event we had in November that we can do better as well. And we're looking at areas where we can continue to develop the ECP model. So for me, it's not about saying, this is something radically new that has to be delivered over 2 years. It's about saying, how can this philosophy of working on an integrated care basis, of breaking down some of the transactional and organisational boundaries that sometimes lead to perverse decision making, contribute to improving that experience of integration. So, you know, by having different funding flows, different contractual mechanisms, different ways of working between teams, can we do even better as a Wandsworth system in providing that experience to all patients and service users on a consistent basis? I don't think this is to invent a completely new way of operating the system over 2 years.
Any other comments? So just one observation which has come up again in the media in the last few days is, I mean, this is a very positive set of proposals with funding associated with it, whether it's enough, open to debate, but nonetheless significant in terms of the health service. But to achieve some of the outcomes that people are fundamentally working to, there are other legs of that particular stool, as it were, notably social care. And more broadly, and going back to the children's thing we talked about earlier, dare one say, sort of local authority funding more broadly in terms of prevention and so on. So I think, you know, I mean, nothing we can do about it here sitting in the CCG, but I think we need to be conscious that this is not the whole story if the sort of outcomes that, you know, we're trying to achieve are going to be achieved, and if joined upness, if that's the right term, is to be really delivered.
So one of the biggest challenges, I think, in terms of understanding the whole system financial challenge and what you're trying to achieve through a local health and care plan and through an ICS is having very little clarity beyond 2021 about what social care in particular funding looks like. We have the BCF, the IBCF, and we have a number of funding formulas that allow us to form a relatively strong view, certainly for the 2 rows that I'm working in, what it looks like. But actually we know that there's a really significant sustainability problem, and what some of the national commentary has been is the counterpart paper needed to this needed to be the green paper on social care funding, which wasn't forthcoming. So I think you're absolutely right, and I think that, you know, one of the issues that I'm sure many SCPs will be highlighting when they respond to this is, you know, there's really good working with local authorities, but actually to understand the local authorities' overall financial context, particularly around social care, is very difficult at the moment, and many local authorities do not have a view beyond 2021 about how adult social care can continue to be funded.
Okay, anything else, Waka?
Thank you, James. One of the things that you mentioned was the legislative changes that may need to take place to allow better integration to happen. I just wondered if you'd heard anything nationally about any consultations that may be happening or any work that's being done to try and look at which legislation is not helpful, and any plans to change that in any way.
So I think that the likelihood of there being a significant sort of portfolio-wide reconfiguration of the NHS system, certainly in this Parliament, is very unlikely, given other priorities. The NHS has been highlighting a number of areas where current legislation could be tweaked or improved. So one example that I've consistently highlighted in National Forum, and I know other people have, is the impact of procurement regulations on the NHS at the moment. I know that as an example, is one specific area where secondary regulations, so not primary legislation, but secondary regulations, are being looked at to see actually do the requirements, particularly on CCGs, to operate procurement in a particular way, support the development of integrated care systems. But I think it will be at that level more than we relook at the legal basis for the organisations in the system. I think, given the difficulties in 2012, I think there's fairly limited appetite around that at the moment.
Okay, thank you very much, very helpful. We've got various summarised minutes here. Any comments or questions anybody wanted to ask on those? No? Okay. Any other business? Nothing has been notified. Anything else? No? And open, what's the right term? Open place, open sesame, open session. Open session. Anything from members of the public present? No? Okay. I just wanted to finish then, if I may, just to note on behalf of the board and Nicola personally, that this is Huda's last meeting as a member of this board, and I think we should just sort of take the opportunity to thank Huda. I think, Huda, you and I are the only last men and women standing from the PCT. So I've worked with Huda now for...
Just you left.
You know who to blame now. But Huda's been, as everyone around the table knows as well and better than me, a real tower of strength, not just at the CCG, but actually before that on the PCT and during the very interesting cluster period. And there's many things one could say about Huda, and I'm sure they will be said when you have your farewell drinks, which we're all looking forward to in a few weeks. But my personal reflection is that Huda has acted as a marvellous bridge across the disciplines of health and prevention and public health. She's acted as a fantastic bridge, particularly latterly, between the CCG and local government, local authority. And personally, I think the great thing about Huda is that she does combine a sort of very positive, you know, sort of can-do, let's make the best of this, let me make it happen, and let's be positive and move forward, even when, you know, the objective observer might say, bloody hell, you know. And I think that, you know, we really would like to thank you very warmly, Huda, and on behalf of us as an organisation, and more broadly, I think the people of Wandsworth have benefited from your presence. So thank you very much indeed. Just to make your bus journey really so embarrassing.
So really, thank you very much. I really was not expecting that, except to say, well, it was his last board, but thank you very much for your kind words. And I really go with that, like, you know, it's a bittersweet moment. It really is. And I have really enjoyed working with you as a board, inside the boardroom and as well as outside the boardroom. One-to-ones with James have been fantastic. You know, colleagues on the Health and Wellbeing Board, we've had really good things that we talked about, and we try to move things in partnership. And Mike on the Public Health Board, and I will be missing people, so I really want to thank you very much. And you know, being here kind of helped me keep my horizon open around the world and not being single-tracked. You know, having moved from the NHS into local government. So yeah, I hope to see as many of you as possible at my leaving do. As I leave, Anna Bryden and Shannon Katya will be acting for now as Directors of Public Health. Initially, we kind of rejected geographical responsibilities, so Sharon Katya will be kind of more looking after Wandsworth, and Anna looking after Richmond, but they will be working in terms of the subject matter expertise, working across both boroughs. And I have no doubt that you will make Shannon and Anna feel very welcome, and they will do their best to continue this bridge with the local with the council. So thank you very much, and thank you for the flowers, and it's really lovely. Thank you.
Okay, well,
I'll have to take an Uber back to the council.
Well, thank you very much, and that's the end of the part 1 meeting. Should we take a 5-minute break and then reconvene?